Thanks to the fan club.
Thanks, Lucy. No. So thanks to you all for being here and coming in to listen to us with this. This, again, obviously relates to Best Start and the recommendations to do with remote and rural competencies. Under Best Start, you're probably aware there's a few short life working groups looking at how to implement different parts of Best Start. And one of them is looking at workforce and education. And under that came these ones looking at remote and rural. So what you can see is that it was looking at, we had to review what are the skills for working in remote and rural areas, and also to look at what arrangements there were between rural boards or rural practice and urban practice in terms of making sure there was clarity about knowing what to do and recognising deteriorating patients. Now, what's quite interesting is that it's been a wee while since anybody has defined what the skills are for midwifery in general, and if you look in the Scottish context, that you're really looking back at the EGAMS report, and although there was an update with a refreshed framework looking much more about skills to do with GERFEC and to do with public health, it hasn't really been looked at again in terms of what are the skills that you require to be confident and competent to work in rural areas. But actually, it hasn't been done for any midwifery, not just remote and rural. It really, so this sort of discussion grew that actually it's not just about remote and rural, it's about midwifery and maternity services. Because also if you look at remote and rural, it's not just a midwife in isolation that manages if there's an emergency. You're looking at who is that wider team and who is it that you're working with. Now, if you look at the last time these skills were looked at, it was in a very, very different context to where we are now. So the landscape has changed completely. Where you used to have GPs who had certain skills or involvement, you had nurses that may have worked as midwives. So in an emergency department or in a where a hub might be based, you had a very different context to what you have now in terms of the skills that were available. So there's much more, there are rural fellows and rural specialties, but there's the movement from where we were even 10, 15 years ago to where we are now has changed. And it's important that you're not just looking at midwifery, that it is actually, it's not just a midwife that provides all the care, it's looking at who that wider maternity service is, which changes in different contexts. Now, we were also, when we were looking at it, what we did was a rapid review of the evidence, which was following what the recommendation was, and what we were looking at specifically was the impact of simulation training. We know we have the SMMDP training. We're very lucky in Scotland that we have a raft of training courses that have been developed, that were developed actually following EGAMS to look at making sure that there was training available for midwives to have the skills that were recommended then. So we've for many years now, we've had a raft of training courses that have been there to absolutely meet the needs of people working in maternity services in Scotland. But simulation training back then was actually quite new, whereas now it's something that we're all used to using, we're all used to working with, but actually what is the impact? What is the evidence? Also looking at things to do with respect, interdisciplinary respect and communication. About rural competencies and skills, obviously, but actually nothing happens in isolation. Wherever you work, the context is huge, and when you're in remote and rural areas, it's very often about the triaging, the discussions, and how you transfer somebody from one place to another in a way that actually is a good experience for the woman, but also a good experience for the midwife, so that they're confident to keep practicing in that environment. So, in terms of that short life working group, we were trying to look at not just about skills as in task-based skills, but actually what is it that makes you able to work within a team that keeps your services sustainable, and basically that keeps you working comfortably and confidently within your team. Now, it was also interesting to look at that actually what was found was that from the evidence and from the evidence that we looked at, that what's very clear is that midwives in rural areas are able to identify risk just as much as midwives in any other context, and that the challenges aren't the skill-based challenges so much as about that communication. It was about the communication barriers, about the transport challenges, and these were the things that actually were really coming through the evidence, and that's that's Scottish evidence, but also evidence from Australia, evidence from other places with remote and rural. So, in the context of that, we did the evidence review, and I'm now going to pass over to Helene, because we had to look at, well, what are the skills? We had the Short Life Working Group. We had an expert group that came together representing remote and rural across Scotland, and this is where we are now. I'll pass you over to Helene.
Okay. So we decided to have a competency survey, although we looked at the evidence that was there and we're pretty sure about what competencies people needed. There were different opinions around as to the range and who should have them, and we thought that it was better to ask midwives, GPs, obstetricians, accident emergency staff, Scottish ambulance staff, all the people that are likely to attend a woman in remote and rural areas, particularly in an emergency. So you don't get out the room without taking one of these little leaflets, if you don't mind, because we're going to talk a little bit about the pilot that we did, but we need lots more information, and particularly from remote and rural staff. So, what sort of things have we seen already? Well, hopefully, this is from the pilot, and you can see from the big blue what do you call that? Big blue banner, bar, that's the word. I'm getting old, so I forget sometimes. Okay, so from that blue bar, you can see that already something like over 80% of the people that have actually filled in the survey so far are working in remote and rural areas. And actually, it's quite interesting when we show you the rest. So at the moment, only 12% of people. What did I say? Did I say remote and rural, or I meant to say urban settings? So only 12% so far have been from remote and rural areas. So we really need you to fill that in and pass it along to your colleagues. So I'm going to highlight a couple of things that were there. So the question was asked, when did you last either attend a patient with a PPH or attend some form of training? And bearing in mind that 60+ of people are working in urban settings where you might expect that they'll see more patients, you can see that a large proportion in the blue circle actually gain their experience either by simulation training, or they haven't had any experience or training over the next week in the last year. And we know now from core mandatory training that's going to coming in that it is important that we do practice these skills on a regular basis. So then we asked people, how do you actually maintain your skill? And people have quite a variety, and you'll see these don't make up to 100 because people might use more than one method. So we've got clinical observation, we've got clinical practice, but you can see the biggest one is simulation, and that's including staff. So it will be interesting when we can pick out from that with the raw data and we have a look at what we think that's actually going to be a similar picture from remote and rural staff. Then you can see the orange bar is those that are doing online training. And online training can be useful in the context that we are, but actually, do you want somebody jumping on your chest if you have a cardiac arrest who's never ever done it or hasn't done it for 10 years, but have practiced it using their thumbs on an app. So, you know, it is important that we do use a combination of things. So again, just having a look at the range, and again, you can see in all of these different obstetric emergencies, you can see that the largest training that's going on is using simulation, because people aren't exposed to enough clinical cases. And this is, again, in light, 60 to 80% of the responders were in urban settings. So I suppose it's kind of reiterating some of the information that we already suspected, was that we do all need to keep our skills going, but also remote and rural is no different from actually some of us working in some of the urban settings. Again, a little bit about perineal repair. These is just some of the information we picked out, and you can see that, you know, quite a large number of people in the survey haven't performed a perineal repair in the last year. So therefore, how do they maintain their competencies? And I suppose it's quite interesting that we can compare the two. And again, a lot is by simulation, and also through clinical practice or observing what other people are doing. So I'm going to pass back over to you to talk a bit about the barriers and challenges.
Well, I cough really loudly with a microphone. So, not surprisingly, what you find out is what makes an awful lot of sense is it's not the skill in isolation. So what you saw from the survey is that simulation training is the main way that people are practicing and using skills, no matter whether they're urban or whether they're rural. But what all the evidence shows is that you can be the best you can possibly be on a mannequin. You can be excellent at it, but it's the context that you're doing that training within and the contextual factors that hugely impact on whether that's effective or not. So it's not the skill in isolation, but the context in which you're actually applying it. So what that means is if you're going to do training, for example, in a rural area, just as much as if you were going to do training in your update in Glasgow, it's making sure that the contextual things are also taken into account. It's not just the hands-on, it's actually what is the advice, what is the discussion going on, where am I transferring to? All these things are hugely can be absolute facilitators to a good outcome, but can also work as a barrier if they're not functioning well. So just focusing on a training that just looks at simulation in isolation isn't necessarily going to change practice. Okay, no, I didn't really. There. So the main issues that came up are, and this is why Helene couldn't send me these slides because there's so many amazing photos, and I remember when you took that one. But the main issues that really came up are about transport, as I said earlier. Because there's no difference for an obstetric emergency in terms of transfer compared to if you're any other medical thing. But maternity is quite different because it's got a pattern of the way it's going. So somebody might be absolutely fine when you decide to transfer somebody. That's a good time to transfer. But it doesn't meet often the criteria in that discussion under the ambulance criteria of being a 999 kind of transfer. Does that make sense? But actually, you want that person to the right place at the right time. So there's the transport issues, and actually people's understanding that a helicopter isn't necessarily sitting flying overhead. So if a midwife doesn't call for a helicopter, a midwife calls for the most appropriate means of transport. So it's making sure that the person who's giving the advice or the consultant at the other end absolutely understands that a midwife's is involved in the clinical. They're not the transport specialist for Scotland. So it's about whose role's whose. And that's about, it comes back, the theme that runs through many workshops and many things it's about communication. It's about relationships and mutual respect between teams and between colleagues. You might work in different contexts, But there's no hierarchy within context. It's about how positive and supportive the communication is, and the feedback, and the reviewing how things are. So that needs to come into any things when we're looking at skills or training, that needs to be absolutely addressed, as well as the hands-on skill part of things. And we have got really, really good examples in Scotland. We have the neonatal retrieval team, for example, who have managed clinical networks, where not only does that team provide training, and they come out to the rural areas to provide training, they also know what every team is made up of, what skills are within that team. They'll also do feedback after any transfers. And if you are transferring somebody, they're the people you're talking to on the phone who are bringing in the right advice and support. And that absolutely, all those elements really support midwives feeling confident in their practice. And this is some of the work that we're doing within the working group, is looking at what does that mean in terms of obstetrics, what would work to support midwives or maternity services in rural areas that we can learn from other services. And technology, it's one of these really barrier-like words. It's nothing fancy. It's usually phones and FaceTime with fancy names. Do you know, it's how can we use things that improve communication? And that's really what we're looking at. For example, we're now using consultant appointments where we have the consultant using it through a FaceTime-like model. Now, that's also looking at what we're wanting to test is when we're doing training, is that consultant also linking into doing quick on-the-job scenarios. So a short amount of time where they are the person that's giving the advice. And so it's about the relationships and understanding what are the skills within that team. Is that advice I'm giving appropriate to the context? And also that ability to feedback and reflect on it. Training plans, I will pass to you.
Okay, so as Jackie's already said, when we're doing any training or anything like that, it has to relate to the culture, the communication, and the context that it's in. Otherwise, it's not any good. And that's why you can see in this that we're using the mobile skills unit quite a lot. That's in Mull. The previous picture, I think, was in Isla. Yes, it was in Isla. So it is important that when you're talking or you're doing any training, that it is about that area. There are local people involved, there are local trainers as well as some others that can help. So what we've said is there are now low costs. As you know, the SMMDP do run everything very cost effective because NHS Education for Scotland do that. But it means that then we can look at the core competencies. And as you know, just recently, Scottish Government have put out draft core competencies for midwives and obstetricians. And, there will be things coming to a place near you and more expectation of their training that we're doing. But as I say, there are courses and things like that we do that are for people like accident emergency, technicians, Scottish ambulance, GPs. And it's important that teams that are working together are training together. I think there's also a recognition that within remote and rural areas, you tend not to have a specialist midwife dealing with special needs in pregnancy or with the perinatal mental health. That is up to the local midwife working in the area, being able to access experts, and that they might have an advanced generalist role and that they need to utilise all these skills at times. So they need to know a lot and be prepared to talk about a lot of things. So I suppose we've been having a look at the different ways that we can deal with that. So thinking about having obstetric hubs, community hubs, and having them linked and having education and training linked. So as Jaki said, you might have an obstetrician working down in Paisley who's dealing with an incident or talking about an incident with the midwives who are training with the GPs in Loch Gilphead. And it's important that there's those links made so that the teams understand each other, and that those that are working in urban areas are actually more understandable or understand what's going on. And again, looking at pre-transport care, also looking at a number of telecare options. We're thinking about running some tele-education where you can practice the skill while linking into somebody who will be in an office somewhere else and can help and advise you, and recording that through films and things like that. So there's a whole lot of things that we're thinking of doing, looking at the sort of transfers that are happening within the services at the moment. So really, I think that's us kind of almost coming to the end. I've kind of mentioned that, but it's important that we do look at in context, use the different things that we have available, and we'd really appreciate if you were to fill in that survey, and we're hoping that wherever you are in Scotland, we will have some form of training. Some of it will be face-to-face, because it's essential that we do have some face-to-face training, but there will be other options like online, but also VC, where you're training, somebody's watching what you're doing and giving your advice. Not only just for training, but also, for example, if you're having a clinical incident, hoping already it happens with neonatal, things that you can phone and your friendly neonatologist or ANNP will talk you through some of the incidents, help you, guide you, that we'll be able to do the same if we have a good obstetric setup. So it doesn't matter actually wherever you are, we're hoping that we will have a training solution for you guys to help you to feel up to date and prepared to deal with all eventualities. Thank you.
We've got time for maybe one question, if anyone has a question. One question. Where's my roving mic? No, you can't.
I can hear you.
There's this lady in the teal. Thank you.
Just you were saying about training opportunities to get the best start rolled out, I guess. As a student midwife in first year, so how do you see the mentor system working to get new midwives on board without having to do any additional training in such?
I think very much. As a student midwife, you're going to be getting all the education and training that's bringing you in. So you're going to be best placed when you qualify to be coming into these models, because you're going to be getting placements as time goes by within these models. But also when you come into practice, the jobs will be based around what that job looks like at that time to make sure you're absolutely supported. But actually think about it as a student midwife. You're going to all those placements. So a lot of the discussions you've heard today, as a midwife coming out when you're qualified, you've had the most recent experience of a lot of different areas, which is a challenge for some of the midwives that have been in practice for a long time. So the jobs will work around the midwife coming in at that time, but also your practice placements will be also moving with the implementation of Best Start. So you're coming in at a good time.
Thank you.
Perfect. Thank you very much.